Welcome everybody to this Wellbeing of Women webinar on miscarriage. Miscarriage is the commonest complication of pregnancy, and it really is absolutely devastating for the people that suffer a single episode, let alone multiple episodes. I'm chair of Wellbeing of Women, which is a charity that supports research and education and advocacy into every aspect of girls' and women's health throughout their life course. And we particularly want to focus under my chairmanship on all the topics that people don't really talk about, the taboo ones, the ones that are difficult, the ones that are embarrassing, the ones that are uncomfortable. And for those of you who are in the audience today, hopefully you'll be able to access our library of webinars that we've been holding over the last 18 months on a variety of topics, from periods to the menopause to all sorts of other things that so often are not talked about, but are so crucial to a woman's life. But today, I have enormous pleasure in welcoming Tulip Mazumdar, because she's an award-winning journalist who specialises in global health. Now, over the last couple of years, Tulip has been reporting on the COVID pandemic across the world, and prior to that, she led the BBC's coverage of the Ebola outbreak from West Africa in 2014 to 2016. And then she subsequently reported on MERS from Saudi Arabia and Zika in Latin America. So this woman really gets around. She's an absolute knowledge bank of all these extraordinary infectious diseases, but she has a special interest in women's health and has covered the fight against female genital mutilation in Kenya, Sierra Leone, and the UK, fistula in Uganda, and obesity amongst women in Qatar. So I suspect you're now wondering why we've invited Tulip as our only guest to join me on this webinar to talk about miscarriage, the commonest complication of pregnancy. I think recently Tulip has shared her experience of baby loss and pregnancy loss, and she's really done an enormous amount to raise awareness through a special series of articles on the topic. And she's also been making a documentary on the very same subject. So I'm going to stop talking now because you really want to hear from Tulip. She's very bravely and very generously going to share her personal story with us. I'd just like to remind everybody that if you would like to raise a question, then you can put it into the chat. We've received a few questions beforehand, and I'm going to pass over to Tulip, and then we're going to have a discussion, which I think she's going to primarily lead about the areas that she'd like to know more about in miscarriage and possibly the research that's ongoing. And then just after 1:30, we're going to throw the floor open to questions. So please feel that you can be part of it. Remember that this is recorded, so you'll be able to access it at a later date if you'd like to. But with no further ado, over to you, Tulip, and thank you so much for coming and sharing with us with your personal experience and your wisdom that you've gained from it. Coupled with, of course, your award-winning journalism. So thank you again.
Thank you, Professor Regan. Hello, everybody online. Thanks for joining. I'm really pleased to be able to do this webinar. I have been, as Lesley outlined there, working on stories about miscarriage for the last, it's been actually the only story I've covered for the last year or so. I mean, we've covered the pandemic as well, but this has been sort of a special project really for me. And I suppose it started when I started having losses myself. Now, you know, again, as Lesley outlined, I've reported from all over the world. I've seen maternal health care facilities in other parts of the world, and I've felt utterly, I've just felt so lucky for the care that I have received here, knowing what it can be like elsewhere. But I've had 4 miscarriages, 2 early losses and 2 late losses. The late losses were both second trimester losses, and they both happened during lockdown, and the previous 2 early ones happened just before. And I think I just couldn't get my head around how something that was so prevalent, so painful, you know, for me and for many others, both mentally and physically, that happens around us all the time, that everyone I mentioned it to would always say either, oh yes, it happened to me, or it happened to my wife, or it happened to my, you know, it had either happened to them or they talked about someone else it had happened to. Just how little it was talked about, and really ultimately how little we still know about why it happens and how best to treat it in the instances where it can potentially be treated. So I was sort of stunned, actually. I kind of, you know, came out of that experience. I mean, after the first late loss, I sadly lost River at 20 weeks. When you have a loss that late, you give birth to your tiny baby. That is one of the options of management, and that's what I did, which again, I knew, you know, from my work and just, you know, intellectually I knew that's what would happen, but being faced with the reality of that was a completely different thing. And I think even now I look back and I just think, did that happen? Like, how is that something that happens? And then you just sort of, you know, go back to work a couple of weeks later. It just seemed like madness to me. So I really, really wanted to explore what we know about why miscarriage happens, what treatments and interventions are being looked into, crucially what the picture is internationally, because as difficult as things are here in the UK, which they are, clearly in other parts of the world there isn't a word for miscarriage in some parts of the world. It's not, it's called spontaneous abortion, or it's not really referred to at all. And that, you know, that causes its own issues. So I really wanted to open it up internationally. So over the last, so from February, really, we've been putting out reports every few weeks. The kind of key areas we looked at were the impact of miscarriage on mental health, the impact on miscarriage on partners, and I'm really glad to see that there are some partners, men mostly, on this webinar as well. I think that's really important that you know, you're engaged with this as well, because it can affect men, and it does affect men and partners of women who lose babies just as much often. And we also looked at why Black women are at higher risk of miscarriage. So yeah, I've sort of been on a journey really over the last sort of few months, 6 months or so, and during that time I also found out I was pregnant again. So I'm 6 months in, and yeah, just still on this journey, which has been terrifying and exciting in equal measure.
Fantastic. That's such a marvelous summary. I mean, I'm jotting a few things down here because you've covered so much, but let's go back to your first point about, you know, why is so little known about it. And I'll share with you, if I haven't before, that when I was a junior registrar in Cambridge in the 1980s, I couldn't understand why nobody could tell me why these women were coming in at 4 o'clock in the morning. And if I did a long weekend on call, I'd have 15, 16 of them. And everyone said, oh, it's very, very common. Look it up. And I looked it up and it just didn't say anything. It just said, oh, they're chromosome abnormalities. These are genetic abnormalities. And that was the end of it. And I had a conversation with a colleague there who was a research fellow. And he said, well, if there's no information, you need to start to do something. And it was, and why I'm telling you the story and the audience, it was Wellbeing of Women who gave me my first startup grant to start that work. And then we started looking into the immunology of pregnancy, and then my career took off with that. But it was thanks to this charity, it was called something different then, that we started to address that. But a lot of people said, and you know, for many years after that, well, why are you bothering about it? It's not really sort of a trendy thing. And it was very difficult to get research money. But I love the fact that you've brought up the issue that although we recognise it much more in the NHS, and we've now got nice guidelines, and we've got, you know, Lancet series on miscarriage, which the audience might like to read, and perhaps Gojda or Caroline we can pop that up in the link up in the chat. But as you say, I've done a lot of work overseas, as you've done reporting overseas, and overseas, it is just not discussed. The woman or the girl is just considered a failure because she's not produced a live child. And before I hand back to you, I think that I'd like to also just emphasize to our audience that what Tulip has experienced is actually quite unusual, because early miscarriage is incredibly common. It's the commonest complication of pregnancy. And to have 2 losses in a row will affect about 5% of all women, minimum. That means 1 in 20 women, whereas women who've had 3 or more, the figures go up to about 1 in 80 or 1 in 100. But that means that most women you know are going to have had an early miscarriage. And of course, the incidence of miscarriage appears to be increasing because we now have very sensitive pregnancy tests that women can do on day 24 or 5 of their cycle, which my mother and grandmother, of course, just had to wait to miss 2 periods and feel very sick. And then they would go to their doctor and wait 2 weeks for the pregnancy test to come back from the hospital. But I'm drifting now. But I think it's so important that in so many countries that don't have health services, women just have no resource at all. There's not even a question, even a consideration of investigating them. So, Tulip, what would you like to share with the audience about the investigations that you've undergone? Because I think the other thing that I think is particularly important about Tulip's case is that she then went on to have 2 late losses, and they are relatively rare. I see a lot of them because of our specialist service, but they are rare. And we usually think that pregnancies that get to 12 or 13 weeks, only about 1% of them are lost after that time. So I would just say to the audience that anybody who knows of someone who has experienced the loss of a baby that's grown to more than 12 or 13 week size, you need to be referred to a specialist clinic for investigation. And as I think I've discussed with Tulip before, often women with late miscarriage have got multiple problems going on, and you can't just stop looking for the problems when you've found one. You've got to go on and look for them all, because sometimes they can have 3 or 4 things that are contributing to it. Tulip, back to you. What did you find? What were the highs and the lows of your journey in the investigative world?
Yeah, well, just very briefly, just to pick up about what you said about the kind of the international picture, I will just mention here briefly that we spoke to people around the world as part of this documentary. So we spoke to women in Pakistan, in Malawi, the Gambia, US, Japan, and others that I can't think of at the moment. And this feeling of shame, of guilt, of it was my fault, that came up no matter where we went in the world, including in the UK. And someone here I just saw, Emily has said, I think there's a problem with the term miscarriage itself. I don't think the word shows the pain that accompanies the actual loss of losing a baby. I think that's part of the reason why people that haven't experienced it either personally or knowing someone that has lost a baby have very little understanding of what actually happens during a miscarriage. And I think, and I agree with Emily there, like miscarriage, we go about trying to define the word miscarriage. We have a look at some of the, the origins of that word, and it's all kind of couched in, a failure to do something, a failure to get to a certain destination. And if the terminology itself, and then in these countries and in the UK, there's this feeling, or there can be feelings of shame and failure, then the women themselves don't want to talk about it. It doesn't get talked about more widely, and therefore it's not seen as a priority to fix. And going back to your point, Lesley, about the funding and how things were, when you were starting off your research, and I know that this has changed, and you'll probably be able to speak more to that, but I think there is still this idea that miscarriage is just something that happens, that it's a woman's issue, and most of the time you can't do anything about it anyway if it's a chromosomal issue. And that's true, right? If it's a chromosomal issue, there is nothing you can do. But my understanding is that chromosomal issues are around half of the time that's where it's a problem, which leaves another half, which I know you're investigating. There are some other, there are things that we need to look into more, and research being done, and treatments that are being developed. But yeah, the idea of, it's inevitable, so let's not talk about it, plus the silence that surrounds it makes it very difficult for it to be prioritized as well. So just a little bit on that. Now, in terms of my investigations, so I hope this is helpful. I'll just take you through each one, because after my first loss, which was a chemical pregnancy, now I didn't even register that one particularly. And again, people have different reactions to each and every loss that they might have, or the first, most people, as you say, only have one. I didn't really register it. I didn't tell anyone about it particularly. I didn't tell my doctor about it. I was like, I had a positive pregnancy test, and then a couple of weeks later, I got my period, and that was that. The second loss I had was much more difficult. It was at 8 weeks. I started. Now, was there a bit of bleeding? I'm just trying to remember. No, I was going away actually for work. I was being deployed to Moria refugee camp in Greece, notoriously awful refugee camp, and I just wanted to check that everything was okay. And I went in, and they actually said that this pregnancy isn't going to continue. And I was simply told, come back in 2 weeks and we'll see if it's gone completely. We'll see if it's gone, if it's cleared itself. And I just sort of said, oh, I'm due to go to this refugee camp on I was covering a maternal health story, pregnancy in this refugee camp. I'm due to go here. Should I be going? And they there wasn't really an answer. They, obviously I wasn't expecting them to tell me if I should go or not, but there wasn't really a discussion about what could happen. So I just sort of quite blindly went off to Moria refugee camp, was bleeding the entire time, was having to use the portaloos. It was grim, but my overall feeling was that I get to leave. I'm going to go back to the UK and have proper care, whereas there will be women here that are going through this that will have nothing, and that was heartbreaking. So after that, I got back from Moria and I had the scan, and they said, yes, the pregnancy's passed naturally, bye. And that was it. And again, because of this whole, it happens, it's common. Because the first one hadn't really registered, I kind of registered this as the first one. And I just was sent on my way. Then I had the third loss, which was in June 2020, and it was at 20 weeks, and it was my little boy River. After that, I was in a state, like an absolute state. It was awful. I didn't know what to do. I'd given birth to a dead baby, a tiny dead baby, and I spent the night in the hospital room with the baby in a cold cot next to me. It was called a miscarriage, and I was like, but that next to me is not a miscarriage, it's a baby. Like, I can see it's a baby. And it really, as you can probably tell, it really kind of messed with my head, because I couldn't get my head around how they were calling it a miscarriage. I was just like, am I going crazy? Is that not a baby? These were the things that were going through my head at the time. And anyway, but again, after that one, I was actually told, I did have some sort of basic tests in hospital. I came back 6 weeks later and had some basic tests, but I was just told, look, you're unlucky, try again. And I just didn't have the energy. And so I was depressed. I didn't have it in me to pursue like what had gone wrong. But we got very luckily we got pregnant again quite soon after that. And again, I was monitored much more closely. I did get some good support from the bereavement midwife, which we'll perhaps talk about a bit later about their roles. But I went for a scan at 16 weeks and was told that there was no heartbeat again. And then I was faced with this, having to go through the entire thing again. I was in the same scan room the second time when they told me there's no heartbeat, with this late loss. I was in the same hospital bed on the labour ward, having Ray, my second baby, Ray, little boy as well. And I was just like, this is madness. This is like literally the definition of madness, isn't it? You keep doing the same thing and expecting a different result. And I just felt like that's what we're doing here. And so after Ray, I almost had no more sadness left. I got all my notes together. I collected everything meticulously. I reached out to anyone I could. I read up a lot. I found out who were the best specialists in the country, and I made contact with them, and and I went private as well. And I had everything together, all my postmortem. I also had postmortems on both babies, because they that was an option, because it was later on in pregnancy. And and yeah, it was a fight, and you have to be in a certain frame of mind, and fight, and that's what it felt like. So ultimately, I haven't been given a categorical reason as to why they happened. There was one test that I did that found that I have stickier blood than I get much stickier blood clotting issues then, and it's a genetic issue that I have. So I've had it in, it's been with me since I had my son. I've got a son as well, he's 4. Didn't affect that pregnancy. Could it have affected the other 4? Yes, but also it could also not have affected them, but it was something. So so then when I got pregnant again, which is this pregnancy, there are interventions. So I'm on blood thinning drugs. I inject myself every day. I'm on aspirin. I had progesterone in the early stages of pregnancy, which again, perhaps Lesley could talk a little bit more about later. And I'm seen very regularly. So I have growth scans every month. Ultimately, from the kind of pieces of the jigsaw we have, they think that it's some issue around the placenta. So the reason I'm actually in Manchester at the moment, where, by the way, there's an amazing pregnancy loss exhibition, which I'll hopefully tell you about in a bit, is I'm being seen by the Tommy Specialist Placenta Clinic. Again, it's a charity. I get to come, and they've seen me and they've been amazing. But you do have to be proactive about it. And I think when you're in that headspace, that is a very hard thing to do.
Well, again, you've covered so many things there. So if you want to interrupt me or pull me to one of the other points, then feel free to do so. But I think one of the first things I'd like to comment about is, knowing about whether it's genetically normal or not. And I see so many couples who've been told, oh, well, it was just meant to happen. Or they're told, well, it doesn't really matter now because you've lost the pregnancy. But in fact, the women that I see, they desperately want to know why. I mean, they can cope with bad news, but they can't cope with, and I wouldn't be able to either, with no news and not knowing why it's happened. So I think that pushing, if you've had repeated losses, for the tissues, however early or however late, to be looked at genetically is really important. I know it doesn't bring back the much loved baby that you've lost, but if you can get some answers, it will actually be very reassuring. And Tulip referred to the fact that she'd had a post-mortem, and that obviously I think is really important. And for any of you, for possibly religious reasons or ethnic reasons, you feel that a post-mortem is against your culture, there are all sorts of ways now in which we can do MRI scans on babies that have been stillborn or miscarried late in pregnancy. We can do biopsies that you won't see any marks on the skin. So we've got all sorts of imaging techniques now that will allow you to get all the answers without having the baby in any way damaged, so to speak. But most importantly, and I hope Tulip will endorse this as well, is that possibly the most important thing, if you've had a late loss or a stillbirth or even another miscarriage, is to actually make sure that someone's looked at the placenta under the microscope, because the placenta often tells you enormous things. It's this thing that gets discarded at the end of pregnancy, but it's a wealth of knowledge if it's tapped. And so often you can find evidence of either infection or inflammation or blood clotting disorders, of which there are many different ones. I mean, we haven't got time to go into all of the blood clotting things, but when I was first doing miscarriage, nobody understood it at all. I mean, this phospholipid syndrome was something that rheumatologists talked about, and we didn't have any genetic clotting tests. They hadn't been invented, and one of the ones that Tulip may be carrying, they're relatively recent on the whole medical space, if you like. So this is a fast-growing field. And before I leave the point about genetics, of course, one of the most exciting things, I think, in terms of research for the future is our ability now to take the sample of blood from a woman who's 8 weeks or 10 weeks, certainly in the first trimester, who may have be threatening to miscarry, or more importantly, has a diagnosis of miscarriage, and being able to take out the cell-free DNA from that woman's blood and to identify whether the fetus was chromosomally normal or not. And why I think that might be so important in the future, and it really is horizon scanning, but the technology is now there and research studies are ongoing. Why that's so important is that we could actually offer so many more women investigations if we were able to rule out, with a relatively cheap test when it becomes much more commonly used, which pregnancies were chromosomally normal and miscarried, which are the ones we really want to investigate, because we've got to ask, well, why has this genetically normal baby not been able to continue? And then controversially, or rather on the other side of the coin, I should say, the ones that are chromosomally abnormal, we know why they've miscarried. So although they need care and whatever investigations are possible, I would say we should be prioritizing the very expensive and more complex investigations for those women who we know then have lost a genetically normal baby. So your thoughts about that, Tulip, because I think, you know, when we do have to keep our eyes wide open and our minds particularly wide open to new ideas. And there've been all sorts of things over the years. But this one, I think, is going to offer an opportunity not just to give women answers, but also to really prioritize where we spend the investigative resource and get the best deal out of it for everybody. Your thoughts?
Yeah, and that's the constant challenge, isn't it, with any area of health? You know, within the NHS, there are limited funds and there's always more you can be doing. I think there are a couple of things. I think the reason why it's so important to know why it happened, or at least do what you can to know what happened, is obviously so that if there are interventions, you can intervene next time. But also it's just knowing, right? Because a lot of what we've covered in the last few months, and what's in the documentary as well, which by the way is available on the BBC iPlayer from today. So if you just type in miscarriage, you'll find it. It's called Miscarriage: The Search for Answers. Is the mental health impact, and how if you like me, and I'm sure many people watching, I'm just kind of reading some of the notes that have come through, and I'm sorry, Lydia, about your loss of Poppy, and just thank you for all the kind words as well, and condolences. That's really kind. I think having just being told, you know, oh, off you go, try again, and you're like, yeah, but what if it happens again? And then it does happen again, and then it happens again, and then it happens again, and you're still being told, oh, you know, it's probably fine, just, you know, next time we'll probably be fine, we haven't found anything wrong with you. That is really hard. And also this idea of blame, again, a lot of the women I've spoken to internationally, and for me as well, I remember after River, who died at 20 weeks, that I remember it was during lockdown. I'd gone for a walk with my friend in a local park. You know, we were doing the whole meter away thing and like walking through the park, but the park closed, and we hadn't realised it had been locked. So we had to climb over a gate basically and jump. And I was convinced that was what caused it. I found it really hard to see that friend until I got the post-mortem results. I couldn't go back to that area of London. I just thought that's what it was, that I jumped and it killed my baby. And, you know, again, like logically and from everything I've read, that just was highly, highly unlikely to be the cause. But I couldn't get it out of my head. So I think having an answer, or at least it being looked at, again, it's the acknowledgement that something has happened that needs to be investigated, but also, you know, if it was a chromosomal issue, which about half the time it is, then there is literally nothing you could have done about that. I mean, it's just, you know, sadly, it's got nothing to do with anything you did. But sorry, going back to your original just about research, I think now what so I'm trying to think where I am now with all of that. I get into so much, lost my train of thought. I mean, we looked into the research that, you know, different organisations are trying to get funding for. So because one of our focus, for example, was on why are Black women at higher risk of miscarriage, and this was really important because, I mean, it's Black and Asian women, but for Black women there was more specific kind of statistically significant results that came out of that Lancet miscarriage series, which has been posted into the chat if anyone wants to have a look at it. Again, that's just to sort of put that you're 40% more likely to have a miscarriage if you're Black. It's an independent risk factor. Now that's just a horrible thing to hear, right? Like there's nothing, because there was no other information, because the research hasn't been done into why that is. Now there are lots of theories. Again, I'm sure Lesley can talk about that, about the lining of the womb, fibroids, microbiome of bacteria, bacteria in the vagina for people from Black and Asian communities and how they might be different. But that, it's kind of not everyone I spoke to about that story were just like, it's just not really good enough that we acknowledge this, and that's obviously really important, but there hasn't been the follow-up, and there isn't the funding there hasn't been forthcoming funding. Why not? This needs to be prioritized. And again, of course, every part of health needs to be prioritized, but with something like this where it's, there's nothing you can do about your color of skin, and because most of the research is done based on white women when it comes to research, and that's another issue with trying to get people from different backgrounds to take part in research and feel part of the conversation around miscarriage and part of the solution. I think that has been that for me was a bit of a, I felt pretty depressed about that, because I spoke to a lot of people who were just like, this is, what do I do with that information? Hasn't really answered your question there about research, but it's something that has come up in a significant way.
You raise a really important point there, Tulip, and that is this terrible gender data gap. And as Tulip was referring to, the vast majority of research in all aspects of medicine, but particularly in miscarriage and women's health problems, have been undertaken in white women. And for example, we know now from our hematological or our blood colleagues that the prevalence of genetic clotting abnormalities is very, very dependent on what racial group you come from. So that's a consideration, and yet you don't see it substratified for that in these research papers, or you haven't done until very, very recently. And there's a massive, massive impact about the social determinants of disease. So the medicine that I was trained to deliver is only ever going to solve a third of anyone's problems. 2/3 of health problems are going to be rooted in the circumstances in which people are born, are educated, live, die, etc., 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 and the socioeconomic things. Now we talk about levelling up, but I think it's all been talk, and I don't see any real action. And I'm a great one for saying, well, now we've done the talking, can we please do the walking? And I think that that is a really important thing. And I'm particularly pleased that the Women's Health vision for a strategy has really focused on trying to look at the inequalities, the racial inequalities and the outcomes of the commonest problems in women's health, like miscarriage. But like you, I found many, many years ago that there were more Black and Asian women coming to me in my very special late miscarriage clinic. And I kept saying, well, why is this? And everybody said, oh, well, we've done that. We've looked for infection. And you mentioned the microbiome earlier. So for the audience who's not medically or as scientifically savvy as our guest is today, I should explain to you that we used to think infections were bugs or viruses that you could send along to the laboratory and grow them and get a result by their appearance. And we now recognize that actually some of the most important infections are due to special areas of the body which have their own microbiome. They have their own biological group of bugs which keep that organ healthy. And when things go wrong, or when you take antibiotics to change those bugs in that environment, that's when problems occur. So we now know, for example, that there are special bugs in the vagina that are totally different from the bugs in the cervix, and that are totally different from the bugs in the womb cavity, and so it goes on. And of course, most importantly, because the reproductive tract is so near the urinary tract in the front and the gastrointestinal tract at the back, crossover of bugs can happen between those three systems, if you like: reproduction, urinary, and gastro, well, gut anyway. And we know now that all those studies are showing that women, for example, who have late losses and premature deliveries are more likely to have an increase of one bad bug or less of a good housekeeping bug. Because remember, it's actually bugs are really important for our health. They're not just things that make you sick. You know, 99% of our bodies are microbiological organisms. It's extraordinary how many we've got. But anyway, I'm wittering on, but we need to move over in about 3 or 4 minutes, I think, to some of the questions that have been posed. But I think it's so important. And just lastly on that point, I think, Tulip, they've posted your documentary link to BBC iPlayer. So you've got an awful lot of reading and watching to do, audience, because you've got the Lancet series, and there are 4 very lengthy papers in that, I can tell you, but also a very good executive summary and patient voice summary. And you've got all sorts of things like as I say, Tulip's fabulous documentary and the reports about ethnicity. But I think the thing about ethnicity is particularly important for us to address. And as I said, I'm really glad that the Women's Health Strategic Group that's being run out of the Cabinet Office now is actually promising to look at this, because it's not okay to say this. We've observed these differences for a long time, and now we've got to address them.
Mm. And I think the only thing I'd add to that really is there are, these studies are costly. They do need to happen, but there are other things that we can be doing, or that the industry can be doing, the sector can be doing to help women and families going through this. And that's all about the care. That's all about how women are dealt with when they go in to see a specialist. Because just being kind, just being like nice and just acknowledging that this has been an awful life-changing event in many cases. Clinicians are busy people, and sadly there aren't the resources in this area to give everybody the time they need, frankly. But I personally, and I've spoken to many people who have gone through this as well, who have just sort of had, and I'm sure it's not meant to be, because no one goes into this line of work meaning to be, cold or not caring. I mean, you become a doctor, nurse, midwife to help people. But just the kind of simple take a breath before that patient comes and sits in front of you, and hear them, right? Like hear them and see them, and so that person feels like it's not just a right, okay, so you've had this and this, right, okay, you need this and this, and then out you go, because quite rightly and fairly there's somebody else waiting who's in another situation, and you want to get through as many people as you can. But I think those small things, and it can just be a turn of phrase, or it can just be, I don't know, a smile or a pause, that can make a massive difference to the mental health impact of this, because it's just that feeling of recognition and being seen that this is something that has wounded me deeply, and I just need help. So I mean, and I know, I mean, I've reported on the NHS, we all see what's in front of us, here, let alone elsewhere in the world. That it's hard, but I would say that doesn't actually cost anything, or perhaps it does just need a little bit of training, right? Some training where these sorts of things can be raised and talked about, and just what a difference that makes, what a massive difference that makes. So yes, I would say that. And the other thing I'd say is that miscarriage is not counted in the UK, right? It's not officially counted, so we don't actually know how many miscarriages there are categorically. I mean, we've got these estimates, and if you don't know the number, then you can't know if they're going up or down, depending on your interventions. And you can't have targets to bring them down, like there are with stillbirth. Quite rightly, they are counted. There are targets to bring them down internationally. In the UK, in most countries around the world, miscarriage is not counted, and in some countries, it's not even acknowledged as a thing. It's not written. Nothing happens. You have a miscarriage, you don't even see a doctor, even if you're very ill with it.
Yeah, it's deeply distressing, isn't it? And I've argued for years and years and years with various health ministers that we should have a register for miscarriage. I think they're frightened by it. I think they're frightened by the enormity of it, and what would they do with the data, which is not I'm not excusing them. I think it's wrong, and that's why I'll continue to push for it. But it really is valuable. And also, I think perhaps we have to turn it around the other way to be convincing to our policymakers and our research funders. You know, if we actually knew what the denominator was of this equation, then we might be able to focus much better on the questions that we need to ask. For example, like grouping people by ethnicity and things like that. And I think that's really, really important. So I think we need to move on. I'm just going to bring you back just before I move on to the questions. You mentioned about the bereavement midwife that had helped you. And I think that might help some of our audience as well, if you'd like to just tell us a little bit about that.
So, you know, and I don't want to be like downbeat about the care and stuff, because again, I was very lucky in many ways. And one of the ways I was very lucky is that my hospital in Southeast London has 2 bereavement midwives. And I was seen by one of them in my second late loss. Now, they do tend to get more involved in later losses than earlier losses, and they wish they could do, you know, my conversations with them, they wish they could do more for the earlier losses, but because they're completely overworked with the late ones, that seems to be kind of where they focus their work. But just some of the practicalities. So when you have a late loss, you know, you do have to think about things like postmortem, something that you could never imagine having to make a decision about. You have to make decisions about what you're going to do with the baby. They sort of held my hand through, we can do a hospital cremation or a burial, or you can do that. In the end, I decided to do it myself, and we had a lovely service for River at home. And for Ray, the second time, we went straight to the crematorium, and we did a bit of a service when we scattered his ashes at the beach a couple of months later. And she actually, Sarah at King's, she was the one that got all my notes together. All my history, I asked her for it. She got it all together. I put it all in order, and I went to see all these specialists with this big thing. They probably a bit overwhelmed by me. But I had all that information, which she helped me get. She was actually with me when I had the scan when I lost Ray. And I think I saw her face drop. I actually remember her face more than anything else, where she was clearly just utterly shocked by what happened. But there aren't enough of them in the UK. I think I'm right in saying that most hospitals don't have them. They are a lifeline in this kind of situation. And in terms of early losses, and I would sort of just like to say, as well as we get to the Q&A, that please do remember that, you know, most pregnancies are successful, that, recurrent miscarriage, which is what I had, and late losses are considered rare, 1 in 100. But obviously when it happens to you, it doesn't really feel like that. But anyway, so I'd keep that in mind, and also, this kind of support, in utterly invaluable. And I just wish there were more of them for other people in different parts of the country and world.
Yeah, thank you. And I think it's important, and I was delighted to, when I talked to you previously, that you've included Tom Bourne and my colleagues in another Imperial Hospital, Queen Charlotte's, who've done such a lot of work on the psychology of this. And I just thought I'd tell you a funny little anecdote, actually, for the audience. I remember in early 1990s, when I started off the recurrent service at St Mary's, after I'd moved down from doing my research in Cambridge, we had a very interested psychology student who suggested we look into this, and everyone said, anyway, to cut a long story short, nobody would fund us, because they said, well, what are we funding? So I said, well, I think these women have terrible psychological problems or mental health problems, and it just wasn't discussed then. And what we showed in that paper, which I had to find alternative funding for because I couldn't get a research council to fund it, was that 1 in 5 of the women who came to the recurrent miscarriage clinic at St Mary's, and that's just one city, had the psychological profile of an inpatient in a psychiatric hospital. And I think that was probably an underestimate, because I think many of the women that I see have got terrible problems, mental health problems, because they feel it's not just what's happened, but that they feel abandoned and discarded by society, and then sometimes, as in some cultures globally, discarded by their families as well. So I think it's absolutely crucial. So I'm thrilled that you've got that team as part of your documentary, which I'm really looking forward to watching later tonight. Now, I've deliberately let this conversation with Tulip go on because in fact, so many of the questions that were submitted beforehand, we've actually answered, I think. I think so. I've got also, if there's anything else in the chat that someone would like to point me to, then we can look at that. But there is one question here about a subgroup of women with repeated miscarriages and who've been labelled as hyperfertility. And I'd like to just mention that, because I think it's a very important story for women and perhaps people who've suffered miscarriage on this webinar to understand. So that work on hyperfertility was actually started off by Jan Brozens, who was one of our trainees at St Mary's, and he's now the Professor of Reproductive Medicine up in Warwick. And he's done some absolutely superb, world-class research into the endometrium, that's the cells of the womb lining, and implantation. I mean, he really is a guru in this field. He's fantastic. What he noticed when he came to work with us at St Mary's was that, well, I think first thing he would tell you if he was here was that he thought it was a terribly boring subject. And he then actually decided that it was a very interesting subject. And what he was particularly interested in are those women who managed to get pregnant every month. And he labeled them as being hyperfertile. And what he did was some very, very clever micro array studies. So these are genomic studies now. He looked at the tissues of those women with miscarriage and those ones with infertility and those ones who were coming in for menstrual problems or something like that, and showed that they were quite different, and that the women with repeated miscarriages who got pregnant every single month that they tried, that their womb lining was less capable of discriminating between the good and the bad embryos. And I'm going to bring that story up because it was all over the newspapers, I remember, and it was all over the BBC, and I gave loads of interviews about it. And I think I was considered to be a bit of a negative Nancy about it all, because the point is that if you correct the womb lining to be more discriminatory against the good and the bad embryos, you don't have more successful pregnancies, you have fewer miscarriages, which, I mean, some people would say, well, okay, I'd rather do that. But I think that so frequently blogs on the internet or on Google or in the private sector are put out to encourage women to have investigations that are not actually going to help them achieve their aim. Because Tulip, you didn't want to go and see miscarriage experts to stop miscarrying as much as you wanted to have a live baby. And I'm thrilled that you've got your 4-year-old and that you're well on track for the second baby. But I think it's very important that people understand that sometimes advice or medical advice is given and they haven't focused on what the really important outcome is, which is having a live birth, as opposed to just stopping somebody having another miscarriage.
And I suppose on that actually, and I've just noticed it's kind of a question, but something that I think it might be useful for you to cover. Nauf, and I'm sorry if I've mispronounced your name, but they say, I am so sorry for your loss, thank you. 2 things that first came to my mind as you were speaking: why has no one gone through preconception health, physical and mental, with me? But I think this is more widely relevant, especially since these losses were during the lockdown, as you have said. The second thing that came to my mind was, has anyone regarded both parents, knowing that sperm health can also be a significant for recurrent miscarriages? Now, I think that last point's really interesting, because we're finding out more, aren't we, about how men's health, including men's age, it's always sort of pointed at the women. And I am, how old am I? 40. So, I am doing this older, and that increases my risk. But for men as well, the sperm quality changes, as I understand it, from about 42, as in 40 as well, not 42. And yeah, with the preconception health as well. So I guess the question would be, what are the basic things people can do to lower their risk of miscarriage in the first place?
Very good question. So sensible diet, exercise, but probably the most important thing is having as normal a BMI, body mass index, as possible, because there has been an enormous increase in obesity across the globe. And I saw some statistics yesterday about a report I was writing a foreword for about the new work coming out of maternity services, showing that now 1 in 3 of our pregnant women are not just a bit overweight, but obese. And it increases every complication of pregnancy. And I used to make myself extremely unpopular with some of my patients. I will share that with you all, when I said, look, you've got to lose weight. And they just thought I was being an insensitive, fattest, grumpy old what's it. But there's now really good data to show that weight, it isn't, that fat isn't padding. It's not, it doesn't just pad you out and it's a bit of extra. It's actually an organ in its own right, in the same way that skin is an organ in its own right, and it produces, the fat produces all sorts of chemicals, and some of them are quite nasty chemicals called cytokines, and they cause inflammation. And that can affect the quality of the ovarian function, the way you develop eggs and the quality of the eggs. But most importantly, in my experience in my late miscarriage ladies as well, that it causes problems with the quality and the depth of the embryo's implantation because of these funny chemicals. So that's why we've worked, and I think you had those tests, Tulip, on that thromboelastogram test, trying to find inflammatory markers, because I thought that was important, and trying to quieten them down if we find them. But weight loss is incredibly important. And of course, for some women, weight loss is crucial to their fertility. They can't get pregnant at a certain, if they put on too much weight. But so that's important. Alcohol should be minimal. I don't think there's any data that says you shouldn't ever, ever have a glass of wine. You might be relieved or not relieved to hear. But I think the other thing to say is that there's so much information now out there on the net, and on the back of buses and in the high street, saying you've got to take all these vitamins, and if you take DHEA or omega-3 and this, that and the other. The only data that is evidence-based about vitamin supplements are that folic acid really does reduce the risks of miscarriage and neural tube defects such as spina bifida, but also miscarriage, and vitamin D. The vitamin D supplements, particularly in the Northwest Hemisphere where we all are really important, but all of those other things are not. Now, just before I pass back to you, I just make a comment about the sperm, which I think is really important. And there are data now about 10 years old to show, some from our unit, some from Jan Brosen's unit in Warwick and other places from the States, showing that there is a contribution of older men. So if you look at epidemiological studies, population studies, miscarriage is higher when men are older as well. And it's assumed that's to do with the quality of the sperm. But I think it's one of the reasons I don't routinely do DNA or semen analyses or DNA fragmentation is that the studies that have shown that the abnormal sperm are in miscarriage patients, they're all, if you like, they're looking at that subgroup of miscarriage, but we don't get many studies reported of men who've had normal pregnancy histories with their partners and who've not had problems in the past. So it's quite difficult to know whether we're just commenting or observing something that's in many, many men, or whether it really is causative. But most importantly, if anyone finds himself in that position in the audience, that all of the studies that have tried to give men antioxidants, again, vitamins and things, and various other supplements have not shown that it improves the outcome, even if it reduces the DNA fragmentation. So it's really important when you're looking at these new studies to ask the question, yes, but where's the control group? And did this really improve the outcome? And I would just finish by saying one of the things that's very interesting about sperm is that when they're very abnormal, they tend to lose their capacity to fertilize the egg. So if you've really got a male factor problem, you're most likely to present with fertility or get problems getting pregnant. Whereas you and I, Tulip, were born with all the eggs we'll ever have. And as we grow older, they grow older and less competent. So, and there's nothing in our eggs that prevents them being fertilized by the sperm. So the sperm lose the capacity to do it, which is that protection, but we don't have a similar one. Over to you, because I think it's really important that you should finish off in our last 4 or 5 minutes of what you'd like to see in the future. Perhaps you'd like to tell us a little bit more about your current pregnancy, or if you feel that's tempting fate, then don't. But I do very much hope that you'll tell Wellbeing of Women what's happened as the outcome, because we'd love to celebrate your success with you.
I will, thank you. I might just read out a couple more of these. There's some really lovely messages coming through. Thank you for people for getting involved and sharing their stories. I think it's really important. Tina has talked about having 5 miscarriages all in the first trimester, 4 weeks, 6 weeks, 9 weeks, the 5th one, and then having sorry, it's just skipped through a bit. Subsequent tests showed shortened cervix, which would require cervical length scanning in the next pregnancy. I decided not to try again as it was just too traumatic. thank you for sharing that. And again, I've heard very similar stories. One of the women I spoke to as part of the miscarriage series talked about how she, you know, she had a stitch put in, and that was an intervention that for her next pregnancy, you know, it was successful. So you know, but again, it's difficult to know what it was that actually made that.
I'm really glad you've picked that one out, because that's an area we haven't touched on. It's an enormous area about structural abnormalities in the uterus, and I confess I used to think it was all a load of rubbish, but apart from a weak cervix, which of course we know is obviously going to be an important cause of late miscarriage and also very early preterm birth. But I've had to eat my words, because over the last 10 years or so, we've now been ensuring that every woman who comes with 5 or more early losses and a single late loss, we bring in for a day surgery procedure to examine them under an anaesthetic, make sure, measure the length of the cervix, make sure that we can see whether, you know, the internal sphincter at the top going into the womb cavity is normal or not weak. But also we've discovered in women with 5 or more losses that they have a really high prevalence of structural abnormalities in the shape of the womb. So many of them have a sort of a heart-shaped top of the womb. And that may not be the cause of all their miscarriages, but you can understand that if the embryo implants several times on an area that hasn't got much muscle and blood supply behind it, that may contribute. But we certainly found that resecting that and taking that heart shape to be more dome-shaped like that and widening the cavity has helped many of the women achieve an outcome. And often those structural abnormalities of the inside of the womb marry up with, or they are joined by abnormalities of the cervix as well. So message again to anyone who's had a late loss, you need to be investigated, and my advice would be you push to get a hysteroscopy and an assessment of your cervix while you're having a very quick light anaesthetic, because it really is important to find those and offer you the opportunities. But women who had lots of early losses also, I think there's a lot of pathology there that we would miss otherwise.
A couple of other quick questions, just got a couple of minutes. I believe my waters broke when I was in labour for my 13th week miscarriage. Is that normal?
Well, if you were miscarrying at the time, then yes, your waters will break, because that's part of the labour mechanism. So the membranes, the sac around the baby breaks, and then the waters drain out. The important thing about that, of course, is that once the waters are broken, the very normal housekeeping bugs in the vagina can get up into the womb and can infect the baby, and then most importantly can infect the mother as well. So that's why they will probably have sped things up after the waters broke, because then you've got a risk of getting an infection.
And a very quick one from Leanne before we finish, because I'm looking at my phone because I've got the answer here from the NHS. The question is, can I ask what the NHS are doing to offer support for the mental health aspects after such a loss? And let me, because I asked this exact question, Leanne. Government response: we're committed to making the NHS the safest place in the world for maternity care and supporting anyone who experiences a miscarriage. Earlier this year, it launched a maternity disparities task force to ensure all mothers and babies receive the best care. Alongside this, we've just set up 26 maternal mental health hubs for 24,000 more expectant or bereaved mothers to access treatment for a range of mental health issues. So let's see if that's actually happened. It's supposed to happen by April 2022. So let's see the end of the month. I must follow up and find out what they actually look like.
28th today, isn't it, of April?
Yeah, so we've got 2 days, 3 days. I can't remember how many.
Okay, but we'll keep on rattling the bars of that cage.
Yeah.
So I'm going to close up now, and I'm going to thank everybody who's made this possible, this webinar. I'm going to thank our fabulously engaged audience, remind you that it'll be available on film, and to encourage you to go and read the Lancet series about miscarriage, and also to watch Tulip's wonderful documentary. And the other thing that I found, somebody asked me in an interview the other day, what was the most useful thing I'd done as a doctor? And I said, well, I think it was probably writing. I don't know if you can see that, writing. Oh, you can't see it. It's a book entitled, I tell you why you can't see it. It's a book entitled Miscarriage, What Every Woman Needs to Know. And it's a very, very cheap paperback. And the number of people who've told me that, I can show you now, the number of people have told me that it's been a real help to them. So I'm not publicising it at all. Any proceeds from this very cheap paperback goes straight into the My Miscarriage charity. But I've had so many letters from women saying, I've never met you and now I don't need to, because the information I've got has given me the confidence to start again or to insist on investigations elsewhere. So I've finished with that thought, and I do hope that you will all want to get more involved with Wellbeing of Women. Go onto our website, www.wellbeingofwomen.org.uk. We desperately need funds to ensure that we've got answers to the questions that Tulip didn't have answered and that I've still got to question, and also yours. So please join us, and join us also in our future webinars, because I absolutely believe that information is power. And the more knowledgeable you are about the problems of miscarriage or menstrual problems or menopause or anything else, the more able you will be able to control what's going to happen to you in the future. So on that note, it's now 2:01, and I'll probably get shouted at by the production team at WOW because we've run over, but it was so fascinating and everyone was so keen to hear all about your story, Tulip. And I think I can speak on behalf of everybody, and there've been many people, nearly 100 on this webinar, and still 74 according to my list here, despite the fact we've gone over time and they've got meetings to go to. I think everyone would like to wish you the very wonderful outcome to this much wanted pregnancy, and I do hope that you'll share the details and possibly a photograph with us that we can put up on our website if you feel that you're able to. So thank you everybody, and thank you to Wellbeing of Women. Please join us, please help us to raise money to undertake very important research, and also to educate women and to advocate for them. For example, Tulip and I'll be banging on the doors of the Department of Health, asking about mental health and things like that, and what are they going to do. So with that, I'm going to close, and thank you again, Tulip. You've been absolutely wonderful, and I'm looking forward to hearing about this baby being born in the not too distant future. Thank you, everyone. Have a lovely rest of the day. Bye-bye.